These are the objectives of our lecture: describing the concept of normal hemostasis, mechanism of blood coagulations, list the most common bleeding disorders and the clinical consequences, laboratory investigations for the diagnosis of different bleeding disorders, and we will discuss briefly the anticoagulant therapy. What do we mean by normal hemostasis? By normal hemostasis, we mean blood is kept in a steady fluid state without excessive abnormal bleeding and without solidification or thrombosis. Thrombosis is also known as thrombophilia. Okay, so hemostasis is to keep blood in a steady fluid state. No abnormal bleeding, no solidification, no thrombosis or thrombophilia. Just like homeostasis, keeping the internal environment, the pH, the electrolytes, and so on in the body. Okay? Normal hemostasis is brought about by the interaction of different systems in the body. Disturbance in any of these systems will lead to disturbed hemostasis. They include, number one, the vessel wall. When there is an injury, the vessel wall will constrict. Okay? It responds by vasoconstriction, which is a neurogenic reflex. This is to prevent bleeding. Following injury of the vessel wall, platelets will adhere to the subendothelial collagen. So we have platelet adhesion. Following platelet adhesion, we get platelet activation, which is the release reaction, and platelet aggregation to form the primary platelet plug or hemostatic plug, which is unstable. Okay, adhesion of platelets to the subendothelial collagen following vessel wall injury is mediated by von Willebrand factor. Okay, von Willebrand factor is essential for platelet adhesion to the subendothelial collagen of the vessel wall. Release reaction means platelets will release the content of its granule, the alpha granules and the dense granules. And then we end with platelet aggregation, and this is to form the primary hemostatic plug, which is unstable, and this is to arrest bleeding, to stop bleeding. Following is the coagulation factors. The aim of the coagulation factors of the coagulation system is to convert fibrinogen into insoluble fibrin, and this is to form the secondary hemostatic plug, which is stable. The fourth system, which is involved in normal hemostasis, is the inhibitors, the naturally occurring inhibitors in the blood. These are antithrombin 3, protein C, and protein S. These are natural inhibitors in the plasma, which are meant to maintain normal hemostasis. And at the end is the fibrinolytic system. The fibrinolytic system, as you know, is made up of plasminogen and plasminogen activators. By the action of plasminogen activators, plasminogen is converted into plasmin. What is the function of plasmin? Plasmin breaks down fibrin into fibrin degradation products, and this is to limit or to localize the fibrin clot. To localize the fibrin clot to the site of injury, to prevent a spread of fibrin. Okay? So these are the four systems which must be normal to have normal hemostasis. Clear? Now, the next slide. This is a diagrammatic representation of normal hemostasis. We have injury, we have reflex vasoconstriction to arrest bleeding, then we have platelet aggregation and formation of the primary unstable plug, then conversion of fibrinogen into fibrin to form the secondary stable hemostatic plug. This is platelet adhesion or platelet function in general. On the surface of platelet, this is the surface of platelet, there are a number of glycoprotein receptors. Each receptor has a specific function. Glycoprotein 1b receptor is the receptor of adhesion. It binds to von Willebrand factor, and then the von Willebrand factor in turn will bind to the subendothelial collagen. So this is platelet adhesion. We need normal glycoprotein 1 receptor on the surface of platelet. We need von Willebrand factor. And then the von Willebrand factor will mediate adhesion of platelets to the subendothelial collagen of the vessel wall. Okay? If there is no von Willebrand, then platelet adhesion will be defective. Another glycoprotein receptor is the glycoprotein 2b3a receptor on the surface of platelets. This is a receptor for fibrinogen, and it is a receptor for platelet aggregation. Okay. معلش البوينتر ما كان شغال. This is glycoprotein 1b for platelet adhesion with von Willebrand factor and then to the subendothelial collagen. The second glycoprotein 2b, glycoprotein 3a, is the receptor for fibrinogen, and it is the receptor for platelet aggregation. Abnormality in these receptors will give rise to disturbed hemostasis or disturbed platelet function. The coagulation pathways. As you know, we have two major coagulation pathways. These are the intrinsic pathway, the extrinsic pathway, and they both meet in the common pathway at the end. The coagulation pathways are made up of 13 soluble coagulation factors, which are activated sequentially, and at the end, fibrinogen is converted into fibrin. They are activated sequentially, they are inactive. They are activated sequentially, and the aim is to convert fibrinogen into fibrin. Okay, we have from coagulation 1 to coagulation number 13. The biosynthesis of some of these factors needs vitamin K. So some factors, some coagulation factors are vitamin K dependent, and these are factor 10, factor 9, factor 7, and factor 2. ممكن تتذكروها بالاختصار 1972, where 1 is factor 10, not factor 1. Okay, these four factors, they need vitamin K to be active. If there is vitamin K deficiency, then these four factors will be defective and you will end with abnormal bleeding. What are the differences between the intrinsic and the extrinsic pathways? In the intrinsic pathway, in means inside. All the clotting factors are within the blood vessel. They are present in plasma. While for the extrinsic pathway, the cofactor which initiates the extrinsic pathway is derived from outside. It is a tissue factor. It is a tissue factor derived from outside the vessel, the plasma. It is from injured tissue. Okay? Few factors are present in the extrinsic pathway, factor 7 and the tissue factor. So clotting is faster. While many factors are present in the intrinsic pathway, as we will see, and so clotting will take a longer time. In the lab, we test for extrinsic pathway by the test prothrombin test, the PT. The PT is a laboratory test by which we test for the intrinsic pathway. And for the intrinsic pathway, we use the activated partial thromboplastin test, APTT. Okay, this is the test for the factors in the intrinsic pathway, the APTT, and for factors in the extrinsic pathway, we do the prothrombin test, the PT. This is roughly the normal range for the PT, between 11 to 14 seconds, and for APTT test, the normal range is 25 to 35 seconds. It is a range. كل reagent عنده range normal range معين بيكون مكتوب معاه. يعني this is not fixed لكن this is just a range. كل reagent أو محلول بيجي على المختبر بيكون معاه normal control reference control. Okay, لكن roughly the PT is between 11 to 14, the APTT between 25 to 35 seconds. This is the coagulation pathways. This is the intrinsic pathway. This is the extrinsic pathway, and they both meet in the common pathway. Factors in the extrinsic pathway are factor 7 and tissue factor. These are the main. Okay, in the intrinsic pathway, we have factor 12, we have factor 9, factor 11, factor 9, and factor 8. Okay, they meet in the common pathway. What are the factors of the common pathway? They are factor 10, factor 5, factor 2, which is prothrombin, and fibrinogen, which is factor 1. These factors are sequentially activated. بالدور كل واحد بيبقى activated to activate the next one. And at the end, thrombin will convert fibrinogen into fibrin. Okay? طيب, where is factor 13 هنا؟ احنا اتكلمنا from factor 1 اللي هو fibrinogen to factor 12 in the intrinsic pathway. The function of factor 13, it is not directly involved in the process. Factor 13 is responsible for cross-linking fibrin strands. بعد ما يتكون الفبرين مهمته إنه يقوي الفبرين clot. It is responsible for strengthening the fibrin clot by linking the fibrin fibers. Okay? It is not directly involved in the reactions, but at the end it acts on fibrinogen to make it strong. Inhibitors of blood coagulations, the natural inhibitors of blood coagulation. These are antithrombin 3, which inhibits thrombin. We have protein C and protein S. They work together to inhibit activated factor 5 and activated factor 8. A means activated. Okay? VA means activated factor 5. A means activated factor 8. Fibrinolytic system is also involved in inhibition of the spread of fibrin clot. Okay, this is normal hemostasis. Now we move to the screening tests for platelets. The screening tests for platelets include platelet count and platelet function tests. This is the normal range of platelet count, 150,000 to 450,000 per cubic millimeter. Okay, 150,000 ل 400,000 per cubic millimeter. By platelet function test, we mean we study platelet adhesion, we study platelet aggregation using a special device known as aggregometer. An expert hematologist can assess platelet function by examining a stained blood smear. From a peripheral blood smear, if we are well trained, we can assess the platelet function. And we can also assess the platelet count. Lakin, the platelet function is now assessed by a device known as aggregometer using different reagents. If we have low platelet count, which is thrombocytopenia, and if we have abnormal platelet function or platelet dysfunction, then the bleeding time will be prolonged. Okay? Low platelet count, disturbed platelet function will cause prolonged bleeding time. Okay, aggregometer is a device which is used to study platelet function, to study platelet adhesion and aggregation. A screening test for the coagulation pathways. In the lab, as I mentioned, we test for the intrinsic pathway by activated partial thromboplastin time, APTT, as well as factor assay or measurement. We do the APTT and we measure or we assay the factor which is in question. Okay, مثلا لو عندنا hemophilia A هنعمل APTT and we measure factor 8. Okay, so these are the two tests for the intrinsic pathway, the APTT, and then according to the situation we measure the factor under test. For the extrinsic pathway اللي هو فيه factor 7 and tissue factor, we do prothrombin time, PT, and we measure or we assay the factor level. For the common pathway defects, both PT and APTT are prolonged. Okay, لو عندنا defect in the factors in the common pathway, that is factor 10, factor 5, factor 2, and factor 1, both PT and PTT will be prolonged. Okay. For fibrinogen, we do thrombin time, PT, and we measure the level of fibrinogen assay or measurement. By the thrombin time, we mean the time taken for thrombin to convert fibrinogen into fibrin. اللي هو بنجيب thrombin as a reagent we add it to plasma وبنحسب الزمن اللي بيحصل فيه الكلوت. Okay, thrombin time is a test for fibrinogen. If it is normal, then fibrinogen is normal. If it is prolonged, then there is a problem either in concentration of fibrinogen or if the function of fibrinogen. يعني either في hypofibrogenemia أو في dysfibrinogenemia. Dys دايما معناها عندنا abnormal. dysfibrinogenemia. واضح؟ Okay. طيب, let us move to hemostatic disorders. Diseases of hemostasis. Diseases of hemostasis arise as a result of either vascular defect, platelet disorder, coagulation factor disorders, abnormality in the natural anticoagulants, or abnormality in the fibrinolytic system. They can be inherited or acquired. All can be inherited or acquired. We will start by vascular disorders causing abnormal bleeding or vascular purpura. Bleeding in the skin has three forms or types according to the size. If the bleeding in the skin is about 2 millimeters, then this is a petechiae. Okay? If it is more than 1 centimeter, if it is large, then this is ecchymosis. And if it is in between 2 millimeter and 1 centimeter, then this is purpura. So, bleeding in the skin is of three types according to the size. It can be very small, petechial hemorrhages. It can be middle size, and this is purpura. It can be large. This is ecchymosis. This is to start with. Vascular bleeding due to vascular disorders or vascular purpura is characterized by easy bruising. يعني أقل لمسة في السكين or في mucous membrane you get spontaneous bleeding from small blood vessels. Vascular purpura mainly affects the skin and the mucous membranes. Okay, vascular purpura can be inherited or acquired. The diagnosis is usually by exclusion of other conditions. ما في test معين, just by exclusion. Example of inherited vascular purpura is hereditary hemorrhagic telangiectasia. Hereditary hemorrhagic telangiectasia. Telangiectasia means dilated superficial capillaries, dilated fragile superficial capillaries. In this condition, the capillaries are very fragile and dilated from the mouth, in the GIT, from the mouth down to the anal canal. So you expect spontaneous bleeding, and if you have bleeding, continuous bleeding from small blood vessels, you expect iron deficiency anemia. Okay? So hereditary hemorrhagic telangiectasia is bleeding from dilated superficial capillaries involving the GIT, starting from the mouth and lips down to the anal canal. Acquired purpura can be in the form of simple easy bruising. في ناس أول ما يحصل لهم أي خبطة في الجسم بتاعهم اللون بيتغير لأنه حصل rupture of blood vessels and purpura. This is simple easy bruising. It is common in middle-aged females. The second type of acquired purpura is senile purpura. This is purpura in old patients. And the cause of senile purpura is degenerative changes of connective tissue due to the aging process. The third type is purpura associated with infections, such as measles and meningococcal septicemia. These affect the vessel wall, resulting in weakening, rupture, and purpura. Scurvy, which is vitamin C deficiency, is also a cause of purpura. Why? Because vitamin C is essential in formation of collagen fibers. When we have deficiency of vitamin C or scurvy, then collagen fiber formation will be defective and there will be abnormal bleeding and purpura. Bleeding due to scurvy occurs in the gum, in the gingiva, in the oral cavity, and characteristically around the hair and hair follicles in the skin. The fifth type of purpura is due to prolonged use of steroids, causing tissue atrophy or connective tissue atrophy. Prolonged use of steroid will lead to connective tissue atrophy and purpura. And the last, and not the least, is an immune-mediated type of purpura, occurs in childhood, known as Haemostasis syndrome. This Haemostasis syndrome is immune-mediated. It is an IgA-mediated vasculitis, inflammation of the vessel wall. Okay? An immune type of purpura seen in childhood. It is IgA-mediated inflammation of blood vessels, vasculitis. واضح؟ Okay. These are purpuric rashes and petechiae. في small dots which are petechial hemorrhages وواحدين أكبر شوية they are purpuric rash. This is a large bleed in the skin. This is ecchymosis. And this is hematoma, collection of blood in tissues. Okay? This is hereditary hemorrhagic telangiectasia, showing dilated capillaries starting from the lips, tongue, and downwards. This is senile purpura due to degenerative changes associated with aging. And this is vitamin C deficiency, scurvy, and the bleeding ما واضح لكن characteristically around hair follicles, perifollicular. Perifollicular means around. Okay? platelet disorders. Again, platelet disorders can be inherited or acquired. Whether inherited or acquired, they can be in the form of reduced count or thrombocytopenia or platelet dysfunction. Both reduced platelet count, thrombocytopenia, and dysfunction give rise to prolonged bleeding time. The normal bleeding time is between 4 to 7 minutes. Okay, this is a normal bleeding time. The bleeding time is a test for platelet count, platelet function, as well as vessel wall integrity. ليه؟ لأنه البليتلتس بتلصق في الفيزل wall. If there is abnormality in the vessel wall, then adhesion will be defective and the bleeding time will be prolonged. Okay, so prolonged bleeding time test platelet count, platelet function, and vessel wall integrity. Causes of thrombocytopenia. Thrombocytopenia can be due to failure of production. This is marrow failure, or it can be due to increased platelet consumption. Platelets are produced normally from the bone marrow, but they are consumed peripherally. Increased platelet consumption can be immune, or it can be in DIC, disseminated intravascular coagulopathy or coagulation. Another cause for platelet thrombocytopenia is abnormal distribution of platelets. This occurs, for example, when the spleen is enlarged in splenomegaly. Why? When platelets are produced from the bone marrow, 1/3 of the platelets are present in the spleen. They are not all circulating in the blood. تلت البليتلتس اللي بتطلع من البون marrow will go and pool in the spleen. When the spleen is enlarged, the proportion of platelet in the spleen increases. So this is abnormal distribution. يعني بدل ما كان في تلت واحد ممكن تلتين البليتلتس بتمشي to pool in this enlarged spleen. So the distribution is abnormal. واضح؟ The third cause of thrombocytopenia is dilutional loss. Dilutional loss occurs with massive transfusion of stored blood. هنتكلم عنها في الآخر. Okay? So these are the 4 causes of thrombocytopenia. Failure of production, which means marrow failure, can be aplastic anemia, or can be isolated failure of production of platelets. Increased platelet consumption can be immune due to antigen-antibody reaction and removal of platelets by macrophages of the spleen, or it can be due to the IC. Abnormal distribution, pooling of platelets in the enlarged spleen. Dilutional loss when massive blood transfusion of stored blood is given to the patient. Immune thrombocytopenia or idiopathic thrombocytopenia. Thrombocytopenia due to antigen-antibody reaction include ITP, idiopathic. It can be associated with lymphoproliferative disorders such as CLL and lymphoma, or autoimmune diseases such as SLE. It can be drug-induced. Different types of drugs are known to cause immune thrombocytopenia. Heparin is known to cause thrombocytopenia. Heparin-induced thrombocytopenia, or HIT. It is the unfractionated type of heparin which is usually associated with thrombocytopenia. Thrombocytopenia and thrombocytopenic purpura can occur following blood transfusion, post-transfusion purpura. Infections can lead to immune thrombocytopenia, such as infection by HIV, human immune deficiency virus and other viruses, as well as malaria. Neonatal alloimmune thrombocytopenia. This is thrombocytopenia in the newborn. It had the same pathogenetic basis as the hemolytic disease of the newborn due to rhesus incompatibility. Neonatal alloimmune thrombocytopenia. نفس الهيموليتيك disease of the newborn due to rhesus incompatibility or due to ABO incompatibility. Okay, these are the different types of immune thrombocytopenia. We will discuss the ITP in some details. ITP, idiopathic thrombocytopenic purpura. Antibodies against platelets. These antibodies, autoantibodies, they coat platelets and then the platelets are sensitized. Sensitized platelets means platelets coated by autoantibodies. Then the platelets are removed by macrophages of the reticuloendothelial system. This will result in reduced platelet count and reduced lifespan. The normal lifespan or the lifespan of normal platelets is 9 ± 2 days. When there is ITP, the lifespan is down to few hours. So the cause of the idiopathic thrombocytopenic purpura is autoantibodies. They coat platelets and then the sensitized or the coated platelets are removed by macrophages in the spleen. We have two types of ITP, acute ITP and chronic ITP. Acute and chronic. They have some differences between them. The onset of acute ITP is sudden or abrupt, cell acute inflammation, while chronic ITP has a gradual or insidious onset. Acute ITP is a disease of childhood, while chronic ITP is a disease of adults, especially females. Acute ITP is preceded by respiratory infection or vaccination, commonly preceded by vaccination or respiratory infection. There is usually a 1 to 3 week history of vaccination or respiratory infection, while chronic ITP is idiopathic. Usually it is idiopathic, lakin sometimes it is associated with these conditions: SLE, CLL, HIV, Hodgkin's disease, and autoimmune hemolytic anemia. Lakin commonly there is no known underlying cause of chronic ITP. Regarding the spleen must not be enlarged. No enlarged, no palpable spleen in ITP, whether it is acute or chronic. If the spleen is enlarged, then you have to think of other causes of thrombocytopenia. The enlarged spleen is not a feature of ITP. It usually favors secondary thrombocytopenia. اوكي الاي تي بي ماله السبين ما enlarged. اذا كان لقينا an enlarged spleen, this is not ITP. Platelet counts in acute ITP is less than 20,000, while in chronic ITP is more than 50,000. In both types, platelets are giant. Platelets are giant. Okay? لأنه giant platelets are hemostatically more competent than the small platelets. إذا شفنا البلاد سمير بنلقى giant platelets. The bone marrow, if we examine the bone marrow, megakaryocytes are increased. They are increased to compensate for the low count. Okay? Acute ITP is short-lived. It continues for 2 to 3 weeks, while chronic ITP continues for months or even for years. The antibody or the immune complex in ITP, in acute ITP, is non-specific. It is not directed against a specific antigen or protein. While in chronic ITP, the antibody or the immune complex is against glycoprotein 2b3a or glycoprotein 1b. يعني شنو الريسبتور بتاعت الادهيجن؟ الادهيجن اللي هي 1b او الريسبتور بتاعت الاجريجيشن اللي هي 2b3a. Spontaneous recovery occurs in more than 80% of cases of acute ITP, while spontaneous recovery is not common in chronic ITP. They need treatment and they can even need a splenectomy if it is severe thrombocytopenia and persistent. Okay? واضح؟ Okay. Let us move further. Platelet function disorders, or before we discuss platelet function disorders, what investigations do we do for ITP? For ITP, we do platelet count, we see the blood smear, and we examine the bone marrow. We find low platelet count, we find giant cells in the blood smear, and we find increased megakaryocytes in the bone marrow. Platelet function disorders or platelet dysfunction. Platelet dysfunction or platelet function disorders. Again, platelet dysfunction can be inherited or acquired. Can be inherited or acquired. Causes of acquired platelet dysfunction. Drugs like aspirin can lead to platelet dysfunction. Acquired platelet dysfunction is also seen in other hematological disorders such as myelodysplastic syndrome, MDS. This is a pre-leukemic syndrome. We will discuss it in hematology too. It is a pre-leukemic or precancerous condition. Another hematological cause of acquired platelet dysfunction is multiple myeloma with hypergammaglobulinemia, with increased immunoglobulins. Platelet dysfunction of the acquired type also occurs in chronic renal failure or in uremia. Okay, these are the causes of acquired platelet dysfunction. The commonest cause of acquired platelet dysfunction is drugs, especially aspirin. عشان كده المريض اللي بيكون بياخد أسبرين بيكون عايز يتعمل له عملية بيكلموه قبل يومين أو 3 يوم إنه يوقف الأسبرين. لأنه إذا كان لسه بياخد في الأسبرين واتعملت السيرجري he is going to develop bleeding لأنه في platelet dysfunction. Inherited disorders of platelet function or platelet dysfunction. We will briefly discuss two types of inherited platelet dysfunction. These are the Bernard-Sollier syndrome, BSS, and the Glanzmann's disease or thrombopenia. Okay, Bernard-Sollier syndrome is a disorder of platelet adhesion. Glanzmann's disease or thrombocytopenia or thrombopenia is a disorder of platelet aggregation. Both conditions are autosomal recessive. Okay, both Bernard-Sollier and Glanzmann disease are autosomal recessive. Bernard-Sollier syndrome is defective platelet adhesion due to deficiency or abnormality of glycoprotein 1b, which is a receptor for von Willebrand factor responsible for platelet adhesion. Glanzmann's disease, thrombopenia, is defective aggregation due to deficiency or abnormality of glycoprotein 2b, 3a, the receptor for fibrinogen and platelet aggregation. Okay, this is glycoprotein 1b on the surface of platelet. It is the receptor for von Willebrand factor and platelet adhesion. It is defective in Bernard-Sollier syndrome. This is glycoprotein 2b3a, the receptor for fibrinogen. It is defective in thrombopenia. Okay, so we have defective platelet adhesion. Investigations of inherited platelet dysfunction. The platelet count is normal. The bleeding time is prolonged. In the blood smear, we have giant platelets, which are hemostatically more competent than the small platelets. We have to do platelet aggregation studies or platelet studies by aggregometer using different agonists or different reagents. Okay? Platelet function study by aggregometer using different reagents or agonists to study platelet adhesion and platelet aggregation. And to confirm the diagnosis, we do flow cytometry, platelet flow cytometry to detect the deficient or the abnormal receptor. Okay, flow cytometry by a device known as flow cytometer. We use different antibodies to study the platelet receptors. واضح؟ يعني we start by simple investigations and we end by more complicated, expensive investigations. This is the result of the aggregometer. You don't need to go through it in details. Just this is aggregometer result. And these are giant platelets. Okay? Aspirin as an antiplatelet drug. From your biochemistry, بتتذكروا arachidonic acid and the two pathways through which it goes. It goes through cyclooxygenase pathway and lipooxygenase pathway. اللي احنا عايزينه is the cyclooxygenase pathway. Arachidonic acid by the cyclooxygenase pathway will give rise to thromboxane A2 in platelets. Thromboxane A2 is a type of prostaglandin produced by the platelets. It causes platelet aggregation. Okay? When we give aspirin, aspirin inhibits the cyclooxygenase enzyme, and so it inhibits the synthesis of thromboxane A2 and inhibits platelet aggregation. Okay, واضح? How aspirin interferes with platelet function? It is by inhibiting the cyclooxygenase enzyme and thus inhibiting production of thromboxane A2. Thromboxane A2 is a prostaglandin produced by platelets and it causes platelet aggregation. No thromboxane A2, then no platelet aggregation, impaired platelet function. واضح؟ Aspirin as an antiplatelet. Okay. We move to the coagulation factor defects. As you know, we have 13 coagulation factors. Any one of them can be abnormal or deficient, giving rise to abnormal bleeding. We will just go through the 3 common types of coagulation factor defects. These are the hemophilia A, which is deficiency of factor 8. This factor 8 is part of the intrinsic pathway of coagulation. Hemophilia B, or Christmas disease. This is due to deficiency of factor 9. Okay? And the third is von Willebrand disease due to deficiency of von Willebrand factor. And by the way, and as you know, von Willebrand factor is part of factor 8. Von Willebrand factor is part of factor 8. Factor 8 عنده 2 parts, von Willebrand and factor 8 clotting antigen. What is the function of von Willebrand? Or what are the functions of von Willebrand factor? One function of von Willebrand factor is platelet adhesion. Okay. The second function of von Willebrand factor is to protect factor 8 clotting antigen from breakdown by enzymes in the circulation. Okay. Von Willebrand factor has 2 functions. Number 1 function is to mediate platelet adhesion to the subendothelial collagen of blood vessels. The second function is a protective carrier of factor 8 clotting antigen. It prevents factor 8 clotting antigen from breakdown by enzymes in the circulation. The defect in the 3 types can be either in the quantity or in the quality, or it can be combined. Okay, it can be reduced concentration, it can be normal function, or a combination of both quantitative and qualitative defects. Hemophilia A is commoner than hemophilia B. Hemophilia A is commoner than hemophilia B. بتعرفوا طبعا هيموفيليا ونقص عامل التجلط الثامن. تسمعوا به أكيد. This is hemophilia A. نقص عامل التجلط الثامن is hemophilia A. Inheritance of hemophilia A is sex-linked or X-linked. This means this is a disease of males. Females are carriers. They transmit the disease to their sons. Okay, this is a disease of males because it is X-linked or sex-linked. The severity of hemophilia A is according to the concentration or the percentage of factor 8. If factor 8 is more than 5%, then this is a mild disease. If it is between 1 to 5%, then this is moderate disease with moderate bleeding. If the concentration is less than 1%, then this is severe hemophilia. As I mentioned, females, they carry the abnormal gene and they transmit the abnormal gene to their sons. Rarely, females can get hemophilia A. This is according to what is known as the Leonization theory. Leonization theory means inactivation of the normal X chromosome. the female has 2 X chromosomes. One of them is abnormal when she is a carrier. If the normal chromosome, X chromosome, is inactivated, then the female will get hemophilia A. This is known as lionization theory. منو التاني ممكن to get hemophilia A من الجينيتكس اللي درستوها؟ تعرفوا تيرنر سيندروم مش كده؟ التيرنر سيندروم عندهم X كروموسوم واحد. مش بتتذكروا؟ التيرنر سيندروم وكلاين فلتر سيندروم ولا ما بتتذكروها؟ Okay, طيب. So, hemophilia A is a disease of males. Females are carriers. This is an example of the inheritance. You need premarital counseling, I think, في السعودية للهيموفيليا A ولا بس للثلاسيميا والسيكل سيل؟ ولا ما عارفين؟ طيب ما علينا. If a hemophiliac father, if the father is a hemophiliac, معناه he is affected by hemophilia A and the mother is unaffected, normal. What will be the expectancy in each pregnancy? In each pregnancy, you expect the females to be carriers and the males to be normal. This is if the mother is normal and the father is a case of hemophilia. All males will be normal and all females will be carrier for hemophilia A. Right. What will be the outcome if the father is normal and the mother is a carrier? There is a 25% chance في كل pregnancy يكون عندنا affected son، يعني الصن عنده هيموفيليا، و 25% إنه الدوتر تكون carrier of hemophilia. This is if the father is normal and the mother is a carrier. 25% chance to have a son with hemophilia, 25% chance for a daughter to be a carrier of hemophilia. طيب, let us see the clinical manifestations. The clinical manifestations include bleeding from cut wounds following trauma or injury, bleeding into muscles, and bleeding into joints. In severe hemophilia, we have severe bleeding from early life. Okay? We get severe bleeding following even minor trauma. We get bleeding in joints, resulting in joint deformities, and bleeding in muscle, causing muscle hematomas. If the hemophilia is moderate, then you get bleeding with moderate trauma. Like rarely we get spontaneous episodes of bleeding. In severe hemophilia, we can get spontaneous bleeding without injury. And if hemophilia is mild, we need extensive trauma or severe trauma to get abnormal bleeding. Okay, these are the clinical manifestations. Abnormal bleeding from wounds, maybe spontaneous bleeding in severe cases. Hemoarthrosis is bleeding into joints, and if this is repeated, you get joint deformities. We get soft tissue hematomas, that is hematomas in muscle, and this is why we have to avoid intramuscular injections. Don't give a hemophiliac intramuscular injection to avoid collection of blood in muscles, to avoid muscle hematoma. Laboratory diagnosis. Hemophilia A is deficiency of factor VIII, and factor VIII is a factor in the intrinsic pathway of coagulation. So, we expect an isolated prolongation of activated partial thromboplastin time. This is the only abnormality, prolonged APTT. The PT, prothrombin time, and the bleeding time are normal. When we find prolonged APTT, and we are thinking of hemophilia A, we measure factor 8 level. We find reduced factor 8 level. So, in hemophilia A, the diagnosis is made by finding an isolated prolongation of APTT and reduced level of factor 8. Treatment, number one is replacement therapy. We have to replace the deficient factor. We can give desmopressin. Desmopressin is a drug. It is an ADH analog. Desmopressin squeezes the endothelial cells to secrete factor 8. Factor 8 is mainly synthesized by the liver, and to some extent it is synthesized by the endothelial cells. ففي المايلد هيموفيليا ممكن ندي the drug desmopressin. الدesmopressin هيحصر الاندوثيليال cells عشان تطلع factor 8. This is in mild hemophilia. Desmopressin to squeeze the endothelial cells. This is to secrete factor 8 into the blood. We give antifibrinolytic agent to prevent lysis of the fibrin clot and to prevent bleeding. And if the joints are affected after the acute bleeding episode, we send the patient to physiotherapy to avoid joint deformities. Okay, these are just the outlines of management. Replacement therapy, desmopressin in mild cases, antifibrinolytic agent to prevent clot lysis and to prevent bleeding from wound, and send the patient to physiotherapy to avoid joint bleeding, joint deformities. What replacement therapy do we give? We can give factor 8 concentrate, which is plasma derived or is synthesized by recombinant technology. We can give what is known as cryoprecipitate, containing all these factors. Cryoprecipitate هو precipitate prepared from fresh frozen plasma. Okay, بنشيل الفريش blood, we separate fresh plasma, and we freeze the fresh plasma at very low temperature, يمكن -30 -70 degrees centigrade. بنشيل الفريش frozen plasma بنحطها في الثلاجة overnight عشان تدوب. هيتكون عندنا precipitate. This precipitate is known as a cryoprecipitate. It is rich in factor 8, fibrinogene, and factor 13. Or we can give fresh frozen plasma. Okay, لكن أحسن حاجة ودائما بنديها هي the factor 8 concentrate. If it is not present, you can give cryoprecipitate or fresh frozen plasma. Complications of hemophilia A. As a result of treatment, hemophilia A can be complicated by factor 8 inhibitors or antibodies. Okay, antibodies against factor 8 can develop as a result as a complication of treatment. لأنه نحن ندي المريض factor 8 من برا. Factor 8 is considered as a foreign antigen. الاميون سيستم ممكن بمرور الزمن يعرفوا انه foreign antigen ويطلع antibodies or inhibitors against factor 8. فقدر ما ندي المريض factor 8 concentrate ما منه فايدة لأنه في antibodies حيكسروه. This is a real and serious complication. Development of antibodies or inhibitors against factor 8. The second complication is transmission of infection. Infections which are transmitted by blood and blood products are hepatitis B, hepatitis C viruses, and HIV. The third complication is bleeding into joints, hemoarthrosis, resulting in joint deformities. ليه bleeding في joint ممكن يعمل joint deformities؟ لأنه the blood which is present in the joint is removed by organization. Removal by organization means fibrous tissue formation. fibrous tissue formation means joint deformities. Okay. تمام. واضح. أي سؤال؟ طيب. Let us move to the next slide. This is hemarthrosis, bleeding in joint, resulting in swelling, redness, and pain in the joint. And this is chronic bleeding into joints, resulting in joint fibrosis and joint deformities. How can we detect a hemophilia carrier? كيف بنعرف إنه this female is a carrier? This is done by DNA analysis of peripheral blood leukocytes. بناخد leukocytes from the peripheral blood, بنعمل DNA analysis to see the defective gene. How can we diagnose hemophilia A antenatally during pregnancy? كيف بنعرف إنه the fetus in utero is affected by hemophilia or not? Antenatal diagnosis. During the first 10 weeks of gestation, we do DNA analysis. We take a chorionic biopsy and we do DNA analysis to see the abnormal gene. In late pregnancy, from the 18th week, we take fetal blood. We take fetal blood under ultrasound. بنعمل ultrasound and we take fetal blood, and in the fetal blood we measure factor 8. Okay, early in pregnancy by chorionic villus sampling, biopsy, and DNA analysis. From the 18th week, we take blood, ultrasound guided fetal blood sampling, and we measure the level of factor 8 in the fetal blood. واضح؟ نوف واضح كله ولا في حاجة عايزة شرح تاني؟ هدى؟ وعد؟ Okay. Let us move to the second type of inherited coagulation factor defect, which is hemophilia B or Christmas disease. Christmas is the first family in which the disease was diagnosed. Okay? عشان كده سموه Christmas disease. This is again the same as hemophilia A, but it is due to factor 9 deficiency. It is the same as hemophilia A, but it is factor 9 deficiency. It is less severe compared to hemophilia A. Less severe than hemophilia A. Investigations to reach the diagnosis, again, we do APTT, it is prolonged. Prothrombin time and bleeding time are normal. In this disease, we measure factor 9 level. So we find prolonged activated partial thromboplastin time and reduced factor 9 level. Treatment is by factor 9 concentrate or fresh frozen plasma. You give the patient fresh frozen plasma, or preferably we give factor 9 concentrate. The third coagulation factor defect, inherited coagulation factor defect, is the von Willebrand disease. As I mentioned, von Willebrand factor is part of factor 8. Factor 8 is made up of von Willebrand factor and factor 8 clotting antigen. The function of von Willebrand factor in factor 8 is a protective carrier of the clotting antigen. It carries factor VIII clotting antigen in the circulation, and it prevents its breakdown by enzymes. The second function of the von Willebrand factor is to mediate platelet adhesion to the subendothelial collagen fibers. Von Willebrand disease is due to deficiency of von Willebrand factor, and it is the commonest inherited bleeding disorder. The commonest inherited bleeding disorders. There are different subtypes of von Willebrand disease. You don't need to know now. يمكن لما تبقوا post graduate تعرفوها. Inheritance of von Willebrand disease is autosomal recessive. This means both males and females are affected. In contrast to hemophilia A and B, which are sex-linked, affecting only males. Von Willebrand disease is autosomal dominant. Both males and females are affected by the disease. The bleeding in von Willebrand disease is a platelet type of bleeding. It occurs in the skin and mucous membranes mainly. لكن if the disease is severe, in the severe type or subtype of von Willebrand disease, you can get bleeding into muscles, you can get bleeding into joints. Again, commonly in von Willebrand disease, the bleeding is a platelet type of bleeding. That is, it occurs in the skin and in the mucous membranes. Investigations to reach the diagnosis, we do APTT and bleeding time, and both are prolonged. The bleeding time is prolonged لأنه platelet adhesion is defective because von Willebrand factor is deficient. APTT is prolonged because von Willebrand is absent, and so the factor VIII clotting antigen is subjected to breakdown by enzymes in the circulation, and so it is also deficient. Okay, two findings for the diagnosis of von Willebrand disease: prolonged APTT and prolonged bleeding time. This is all about the inherited coagulation factor defects. Now we move to the acquired coagulation disorders. Acquired coagulation disorders. ناخد 5 دقايق بريك. أنا فترت من الكلام أكيد وأنتوا تعبتوا من التركيز. 5 minutes only. Okay? Okay. Inherited acquired coagulation factor defects. Acquired defects of coagulation can be the result of deficiency of vitamin K dependent coagulation factors, can be the result of liver disease, the result of kidney disease. It can be in the form of DIC, development of coagulation inhibitors or antibodies against coagulation factors. It can be miscellaneous due to causes such as paraproteinemia in multiple myeloma. It can be due to the use of unfractionated heparin, or can complicate massive blood transfusion. Okay. Deficiency of vitamin K dependent factors and acquired coagulation disorders. As I mentioned, the vitamin K coagulation factors are factor 10, factor 9, 7, and 2. Examples of coagulation defects and bleeding due to deficiency of these factors is seen in hemorrhagic disease of the newborn. We will discuss it in details. Biliary obstruction, malabsorption of vitamin K, and the use of vitamin antagonistic therapy, such as the use of warfarin anticoagulant. Vitamin K, as you know, is a fat-soluble vitamin. It needs proper fat absorption to be absorbed. And as you know, for proper fat absorption, you need bile. Okay, so when there is biliary obstruction, no bile reaches the intestine, and so there is malabsorption of vitamin K and deficiency of vitamin K dependent factors. Okay, malabsorption of vitamin K as part of the malabsorption syndrome will also cause deficient coagulation, vitamin K dependent coagulation factors, and acquired bleeding. What about vitamin K antagonistic therapy? Vitamin K is needed by vitamin K dependent factors to be active. They are synthesized and in active form. To be active, they need vitamin K. Vitamin K is needed by these factors for gamma carboxylation of glutamic acid residues in the molecules. Okay? Vitamin K is needed by these factors for gamma carboxylation of glutamic acid. And gamma carboxylation is important for these factors to be able to bind the surface of platelets, the phospholipid surface of platelets in the coagulation reactions. Okay? So vitamin K is important to produce the physiologically active forms of factor 10, 9, 7, and 8. Without vitamin K, they are inactive. They cannot bind to the phospholipid surface of platelets on which the coagulation reactions take place. When vitamin K is used for production of these active forms, it is converted to inactive vitamin K epoxide. Vitamin K epoxide is reduced by an epoxide reductase into active vitamin K. Okay, warfarin inhibits this enzyme. It inhibits the reductase enzyme, and thus it prevents the conversion of inactive vitamin K epoxide into active vitamin K. So warfarin is vitamin K antagonist by inhibiting the reductase enzyme. واضح؟ واضح كيف الورفرين acts as vitamin K antagonist and how it acts as an anticoagulant by interfering with the formation of the active forms of vitamin of the coagulation factors. Okay, it inhibits the conversion of the inactive vitamin K epoxide into active vitamin K. This is by inhibiting the reductase enzyme. Hemorrhagic disease of the newborn. Hemorrhagic disease of the newborn present usually during the first 2 to 4 days after birth. And usually bleeding is from the umbilical stump. It is mainly seen in breastfed babies. And this is because of the low content of vitamin K in the breast milk. Hemorrhagic disease of the newborn is due to vitamin K deficiency and thus deficiency of vitamin K dependent coagulation factors. Causes of hemorrhagic disease of the newborn include low vitamin K in breast milk, so it is common in breastfed babies. الفورمولا milk contains enough vitamin K فما بيحصل فيهم كتير. It is due to immaturity of the liver of the newborn and so decreased synthetic function, and it is also due to the absence of gut bacteria which normally synthesize vitamin K. one type of vitamin K, which is the menaquinone or vitamin K2. عندنا two sources of vitamin K. Endogenous menaquinone produced by gut bacteria. وفي newborn the gut is still sterile, it has no bacteria. Okay. وفي نوع تاني the exogenous vitamin K ده في الليكوينون ده بناخده من برا أو في الدايت. فالبيبيز they have the newborn عنده sterile gut, no bacteria to synthesize vitamin K. This contributes to the development of hemorrhagic disease of the newborn. واضح؟ In hemorrhagic disease of the newborn, both PT and APTT are prolonged because mainly of the immaturity of the liver to synthesize the coagulation factors. It is treated by 1 milligram intramuscular injection of vitamin K. And if the bleeding is severe, we give fresh frozen plasma with the vitamin K injection. To prevent hemorrhagic disease of the newborn, all newborn babies are given 1 milligram vitamin K as prophylaxis. Okay, vitamin K is given to all newborn babies as prophylactic measure against hemorrhagic disease of the newborn. Hemostatic disorders in the liver. We are not going to discuss it in details لأنها there are too many abnormalities. It can be in the form of bleeding from the start, or it can be in the form of thrombosis and DIC and then complicated by bleeding. At the end, the result is bleeding. It is multifactorial. Hemostatic disorders in the liver and liver disease is multifactorial. Disseminated intravascular coagulation. You discussed DIC in your thrombosis lecture in hemodynamics course في الباثولوجي مش كده؟ Disseminated intravascular coagulation or consumption coagulopathy. Disseminated means widespread formation of thrombi inside the circulation, intravascular. This is a systemic thrombohemorrhagic disorder. The whole body is involved. It starts by thrombosis and ends by bleeding. What happens in disseminated intravascular coagulation is as follows. There is activation of the coagulation system with consumption of clotting or coagulation factors. There is consumption of platelets and thrombocytopenia. Consumption of natural inhibitors of coagulation trying to maintain normal hemostasis. Okay? And a reflex activation of the fibrinolytic system to limit the spread of fibrin clots. This is what happens in DIC. It starts by thrombosis with consumption of coagulation factors, consumption of platelets, and then it ends with bleeding. Activation of coagulation factors and platelets will lead to intravascular formation of fibrin and thrombotic occlusion of blood vessels. This will result in ischemia with ischemic damage and multi-organ failure. At the end in DIC, we have multiple organ failure. There is also depletion of platelets and clotting factors, resulting in severe bleeding. consumption of platelets and clotting factors will lead to severe bleeding at the end. The fibrinolytic system is activated to maintain hemostasis, to lyse the fibrin into fibrin degradation products to limit spread. واضح؟ طيب. These are causes of disseminated intravascular coagulation. We have infections, which can be bacterial infections, it can be protozoal infections, it can be viral infections. Okay? Malignancies, commonly mucin-secreting adenocarcinomas and acute myeloid leukemia M3 زي ما هنعرف في hematology 2. DIC occurs also as an obstetric complication. درستوا إنه في DIC in the amniotic fluid embolism. مش كده؟ You get also DIC in other obstetric complications. And there are other causes. Too many causes of DIC. This is the pathogenesis. We have widespread endothelial damage. Endothelial damage will lead to activation of coagulation factors and activation of platelets. This will result in widespread thrombosis, okay, in the whole circulation. As a result of activation of coagulation factors, platelets, and formation of widespread thrombosis, you get decreased clotting factors, decreased platelets, and widespread bleeding. Increased activity of the fibrinolytic system will break fibrin into fibrin degradation products, FDPs. FDPs, fibrin degradation products. So all the coagulation times are prolonged, and there is thrombocytopenia together with increased FDPs in the IC. This is a skin bruise in the IC. This is DIC complicated by purpura. And this is DIC complicated by gangrene as a result of occlusion of the blood supply by thrombosis. Investigations and lab findings. All coagulation times are prolonged. Prothrombin time, activated partial thromboplastin time, and thrombin time. Thrombin time is prolonged because fibrinogen is consumed in formation of fibrin. Reduced fibrinogen level. Due to increased fibrinolytic activity, there is increased FDPs, fibrin degradation products. Platelets are reduced, that is thrombocytopenia, and in the blood smear, we find microangiopathic changes. Microangiopathic changes in the blood smear. Why? Because the vessel wall is abnormal. There are too many thrombi. So the RBCs are subjected to trauma. This will result in red cell fragmentation. All these are red cell fragments or schistocytes. This is what is known as microangiopathic changes. Red cell schistocytes or fragments in the blood smear. This is a nucleated red cell, and this is a monocyte. Again, laboratory findings, prolonged PT, prolonged APTT, and prolonged thrombin time. Prolonged thrombin time is because of reduced fibrinogen level. Fibrinogen is consumed in formation of fibrin. Increased FDPs, fibrin degradation products, thrombocytopenia, and microangiopathic changes in the blood film or in the blood smear, red cell fragments or schistocytes. Treatment or management of DIC. You have to treat the underlying cause. If there is septicemia, for example, you have to treat the septicemia. If there is M3, you have to manage as much as you can. And if there is septic abortion with infection, you have to treat the septicemia. And then you give replacement therapy. We give fresh frozen plasma. We give factor concentrate to replace the lost factors. And we give platelet concentrate. You replace the loss. The last part of the hemostatic disorders is the anticoagulant therapy. Anticoagulant therapy, الأدوية المضادة للتجلط. We have two types of anticoagulant drugs. One given orally, such as a coumarin group. Example of the coumarin group of anticoagulant is the warfarin. This is an oral anticoagulant, warfarin. It is given in the form of tablets. The second type of anticoagulant is injectable, and it is heparin. Anticoagulants are used either prophylactically to guard against thrombosis or for the treatment of thrombotic conditions, and it is also given as prophylaxis for patients with prosthetic heart valve. أي مريض عنده صمام تغيير صمام بياخد prophylactic warfarin for life. This is to guard against thrombosis, cardiac thrombosis. Okay, so anticoagulants are used either prophylactically or therapeutically to treat thrombotic conditions, such as DVT. How do we monitor anticoagulant therapy in the lab? Patients on anticoagulant should be monitored closely for adjusting the dose. عشان ما يحصل لهم overcoagulation and bleeding وما يحصل undercoagulation and thrombosis. They must be closely monitored by laboratory tests. If the patient is taking heparin, we follow him by APTT, activated partial thromboplastin time. And if the patient is on oral anticoagulant such as warfarin, we do PT and INR. Okay? For heparin, you do APTT, and for warfarin and other oral anticoagulants, you do PT, and then you read the INR from the table provided. Let us see what is INR. أي نتيجة بتاعت مريض بياخد وارفرين لازم يكون فيها PT، نتيجة فيها PT in seconds ومعها رقم تاني اسمه INR. INR is International Normalized Ratio. International Normalized Ratio. This concept was introduced by the Hematology Society to standardize the result of PT of patients taking warfarin, to make it easy for follow-up anywhere in the world. لأنه الرياجنتس اللي بنستعملها for PT عندها different sensitivity. النتيجة in seconds بتختلف. مثلا if we have a blood sample for PT خدناه على مستشفى أبحى الخاص. في مستشفى أبحى الخاص بيستعملوا رياجنت من شركة معينة. طلع البي تي في 18. نفس العينة أخذناها على مستشفى عسير. في مختبر مستشفى عسير بيستعملوا بي تي من شركة رياجنت من شركة تاني. فالنتيجة طلعت لنا سي 14. They are different, although the sample is the same. This is because of the different sensitivity of the reagent used in the two labs. To standardize the result, دخلوا الconcept of the INR. كل PT reagent is provided with a table. You read the INR from the table provided. Okay? You convert the seconds into figures INR to standardize the result for the patient to make it easy to follow up the patient. لو البيشنت مشى مستشفى عسير، مشى أبحى الخاص، مشى أمريكا، مشى بريطانيا. Okay? It is a concept to standardize the result to make easy the follow-up of the patient anywhere. واضح؟ بعدين إن شاء الله لما تتخرجوا أي نتيجة بتاعت PT for a patient on oral anticoagulant must have PT in second and INR. The INR in most patients is should be from 2 to 3. For patients with prosthetic valves, it should be between 3 and 4. Okay? This is the range of the INR in most patients, and this is the range for patients with prosthetic heart valves. واضح؟ Okay. Patients on anticoagulants, on oral anticoagulants, shouldn't be given intramuscular injection to avoid muscle hematoma. برضو زي ناس الهيموفيليا don't give intramuscular injection to avoid collection of muscle hematoma. And by this we end our hemostasis lecture. في أي سؤال? Any questions?